Welcome, everyone. Thank you for joining. This is a new medical education webinar series hosted by the RUNX1 Research Program. I'm Katrine Erickson, the Executive Director of the RUNX1 Research Program. And while some of you may have heard of us, may be familiar with the RRP, some of you may not be. So for those of you, we are a nonprofit organization dedicated to supporting patients with inherited hematologic malignancies, specifically patients who have a disease caused by germline mutations in RUNX1, which also results in a platelet deficiency, and thus the disease is commonly referred to as RUNX1 familial platelet disorder. Devastatingly, RUNX1 FPD patients have about a 50% lifetime risk of developing a heme malignancy, and most frequently that malignancy is either MDS or AML. We were founded by the Babbage family, shown on the left there, whose single goal is to support research that could enable the discovery of a cancer prevention therapy. In addition to committing over $11 million in research dollars to date, we facilitate collaboration through regular convenings, which always have patients at the table. And we conduct outreach to raise awareness about the disease and similar inherited hematologic malignancy predisposition syndromes. You may be wondering why we are supporting a webinar series on comprehensive molecular profiling. And that's really because one of the most common ways in which our families are diagnosed is when there's a relative that was diagnosed with a hematologic malignancy, and a physician orders a somatic mutation panel and uncovers a suspicious RUNX1 mutation. And the story then unfolds. So we think it is paramount for clinicians to understand the value of molecular profiling and the many insights that can also be gained through such testing. And as you'll learn from our speaker and our panelists today, those insights can ultimately impact treatment options, treatment outcomes, and in some cases, even care of family members. So here's our agenda for the webinar today. We'll begin with a presentation by Dr. Dan Pollyea on comprehensive molecular profiling in MDS and AML, the standard of care. Then we'll host a half-hour Q&A discussion with Dr. Mannis from Stanford University and Dr. Stein from Memorial Sloan Kettering Cancer Center. Okay, without further delay, welcome to Dr. Pollyea, Professor of Medicine, Associate Chief of Clinical Affairs in the Division of Hematology at the University of Colorado School of Medicine.
Hello, everybody, and welcome. I'm Dan Pollyea from the University of Colorado, and very excited to bring to you our presentation entitled Comprehensive Molecular Profiling in MDS and AML, the Standard of Care. So as we continue to progress in our understanding of the biology of AML and MDS, it's very exciting to know that very sophisticated testing techniques that only a few short years ago were only available in a research laboratory setting are now available in the clinical setting and are in fact the standard of care. And we're going to talk a little bit about what those are, how they help us, and what we think we should all be doing as a community to properly diagnose and treat our patients. The molecular era for our disease is going into our second decade already, if you can believe it. And it was really ushered in with this New England Journal of Medicine paper in 2009 from the TCGA group, in which they sequenced for the first time the whole genome of a patient with cancer. And that happened to be an AML patient. And what they found from just that one patient was enough to really send the whole field down a new and exciting trajectory, because it showed that there were mutations in patients with AML that we had never appreciated or understood. And as our community so often does, very soon after publication of this type of data, the whole community was doing similar tests and studies until we came to understand that there are a sort of discrete number of genes that can be mutated in AML patients and MDS patients as well. Through large-scale efforts, such as the New England Journal of Medicine paper on the right, we were really able to determine the incidence of the presence of many of these mutations, finding some of them to be very common, others less so, and the prognostic value of these abnormalities. And now, just a short time later, this is something that we can all do for every single one of our patients without whole genome sequencing. Just by knowing 50 or so gene panels of the most likely mutations that would cover greater than 95%, we can apply those panels to patients and understand the molecular underpinnings of their disease, really fully understand what's making their disease tick. So it's a really, really exciting time for us in this field. As a result of this work, there's consensus recommendations from here. You see the NCCN guideline panels for AML and MDS that this type of testing should be performed. And I think the consensus really is that targeted next generation sequencing panels or large panels of genes identified by PCR technology should be performed in every AML or MDS patient at diagnosis, and then again at progression. And I think that that really is an important recommendation that impacts treatment selection, prognosis, and outcomes. Other important organizations like the International Consensus Classification Group, the WHO, similarly have these recommendations, and use of bone marrow or peripheral blood if enough disease is circulating in the peripheral blood is appropriate. And it's so important that if this is not available at an individual's institution, it's recommended that the sample be collected and stored so that it can be performed at an institution capable of doing this testing. So I've got a couple of cases I want to take you through to point out the way in which testing changes all of these different elements of the modern approach to these diseases. And I also just want to point out that the lines between MDS and AML have been significantly blurred recently for good reason. It's always been an arbitrary distinction to make a diagnosis of MDS versus AML, in which 20% blast is sort of the cutoff. The biology of these two diseases really doesn't differ when there's increased blasts that do or don't cross the 20% threshold. So pretty much all of the recommendations and discussion we're having here today apply to MDS with increased blasts as well as to AML. So it's important to remember, and I think going forward, our classification systems will recognize that lack of distinction even better. The first case here is a 52-year-old woman who had leukocytosis. So she had no significant past medical history and presented with 2 weeks of fevers and pneumonia. And these symptoms didn't resolve with a prolonged course of antibiotics. She began to have a worsening dyspnea on exertion and a new petechial rash. And she was found to have leukocytosis with a white blood cell count of 34,000, accompanied by anemia and thrombocytopenia. Bone marrow biopsy was performed. It showed evidence for hypercellularity with an increase in the myeloblasts as identified by their phenotypic signature here. So all this is consistent with a diagnosis of acute myeloid leukemia in this 52-year-old otherwise healthy woman. So it is recommended that chromosome testing be performed, and that was done in this case. This patient had a normal karyotype. This applies to about 50% of AML patients, especially in the younger age category. And so historically, we would have been left at sort of a shrugging shoulders situation at this point, and we would say, well, there's no good risk factors, but there's no poor risk factors. So this is intermediate risk AML. And that's kind of where it would begin and end. But because of the gene profiling testing that we can do, we can get a lot more granular by doing next generation sequencing on a patient such as this and finding which of those 50 genes might be mutated to help us understand the prognosis. So this is a table from the NCCN guidelines for AML. And you can see that favorable, intermediate, and poor risk disease are all listed here. And many patients find themselves in one of these categories based on cytogenetic or chromosome testing. But as I said before, if you are the 50% that has a normal karyotype, the only way to really risk stratify outside of intermediate risk is with gene testing. And so for our patient, cytogenetic abnormalities not classified as favorable or adverse, which would put her in the intermediate risk group if all you did was cytogenetic testing. But in this case, the patient is noted to have a biallelic CBP alpha mutation in the BZIP region of the gene. So now this patient is situated in the favorable risk category because that gene testing was done. And so this makes an enormous difference in this patient's treatment plan because many patients who are young and otherwise fit, once they get into a remission, would be taken to an allogeneic stem cell transplant as their curative plan. But I think if you are in the favorable risk group because of this CEBP alpha mutation, for instance, you would be considered to be potentially curable with chemotherapy alone. And many would not receive a transplant in first remission. So this is a situation in which gene testing has a massive difference on a patient's treatment plan, the difference between getting an allogeneic stem cell transplant and not getting a transplant. So the second case is a 82-year-old male with relapsed AML. So this patient was diagnosed 3 years ago after progressing from MDS, and the comorbidities and age made him a poor candidate for intensive induction chemotherapy. This patient was treated with venetoclax plus azacitidine and achieved a remission after 1 cycle. He remained on sequential treatment cycles for 3 years, and now 3 years into treatment is again requiring blood transfusions, and there's a notation of peripheral blood blasts detectable. So this prompts a bone marrow biopsy, and the bone marrow biopsy is hypercellular and shows recurrent AML with 30% blasts. So cytogenetics in this patient reveal a trisomy 8. At this point, one would say that treatment options are quite limited. This is certainly not a patient that would be eligible for an intensive salvage chemotherapy regimen. And really, there aren't any other conventional low intensity regimens, without knowing anything more about this patient, that I think we would have particular promise for. However, the physician performed comprehensive molecular profiling showing the presence of an IDH1 mutation at a variant allele frequency of 35%. So now all of a sudden, this patient goes from not having any reasonable options to having 2 potential treatment options. So there's ivosidenib, the IDH1 inhibitor that was approved for this situation a few years back, and now olutasidenib, the newer IDH1 inhibitor that is also approved for patients with relapsed AML with an IDH1 mutation. So, this is a situation where performing the molecular testing at this point, in this case, at progression, allows for the recognition of treatment options that otherwise would not have been available. So another important reason to explore comprehensive molecular testing, and that's really why this is a standard of care recommendation. And I think we're all very excited about the hopefully pending availability of more targeted therapies for patients with both particular gene mutations that can be found with molecular testing, and then even other types of targeted therapies for non-mutational targets. So for FLT3, we have quizartinib and potentially crenolanib. For p53, we have a few therapies that may have some promise. The menin inhibitors have potential activity against NPM1, as well as the chromosomal abnormality of the KMT2A gene rearrangement. Then there's others as well. There's vaccine therapies and other therapies that might be able to take advantage of splice gene mutations. So I think it's very exciting times for new therapies that can be discovered for patients who have particular abnormalities associated with their disease. All the more reason it's necessary to do this type of a testing. Comprehensive molecular profiling, like I said before, is really recommended to be performed at diagnosis as well as relapse because this can impact prognosis as well as choosing therapies. And I think we've seen improvements in outcomes. So with the advent of FLT3, IDH1, and IDH2 inhibitors and therapies directed against those gene mutations, we have seen that these patients can do better than expected with other conventional treatments. And I think that's why these have become the standard of care. Molecular testing can also tell us other important information about a patient. We are now discovering for the last several years that myeloid malignancies have a propensity to cluster in families. We've known that for a long time, just through observation. And it's not the typical situation, but those of us who treat this enough know that this comes up significantly in patients' families. And we haven't before had the tools to understand this, but now we're starting to. And these can be explained by inherited germline mutations that patients are born with that increase the propensity for them to develop hematologic malignancies, in our cases, for our purposes here today, myeloid hematologic malignancies. Some of these gene mutations are covered in the traditional next-gen sequencing panel, but not all of them are, because there are certain panels that are really specific for patients who have a suspected germline mutation that should be considered when there's that appropriate family history. So this figure basically shows in a gene sequencing panel, you would expect to see pretty much all of these genes in black or green listed in the frequency table here. These are all very traditional myeloid gene mutations that are included in really any somatic panel you might find. But what's interesting is that these 5 can also have a germline component. And so that can apply to 20 to 35% of the gene mutations that patients can have. That's what's represented by these 5 red boxes. So sometimes these mutations will come up, even if they are germline, in a panel that's designed to detect somatic mutations, because while these are more common to be somatic, there are times when these can be germline and therefore can be discovered in a traditional panel. I guess what that really shows is that even though these are relatively rare situations, they add up. And so we think that a significant minority of our patients with myeloid malignancies have their disease derived through these germline mutations. And so a lot to be learned here, but it's very important that we need to be thinking about these and testing for them so that we can get better at diagnosing, because we think the incidence may be upwards of 15% of these patients. And there are clear implications for patient family members who are not showing symptoms necessarily at the time that one patient family member might be. So this is a case of a 30-year-old woman who has a lifelong notable low platelet count. She was really appreciated to have this during her first pregnancy, which was 12 years ago. Her mother had died from complications from a stem cell transplant that she had for a diagnosis of AML at age 55. This patient presented with 2 weeks of worsening fatigue and dyspnea on exertion. She had anemia and thrombocytopenia sort of outside of her usual range of already low platelets. And a bone marrow biopsy did confirm AML with monocytic differentiation. She had a complex karyotype, as you can see here. And a gene mutation panel showed mutations in NRAS with a VAF of 41%. And also the mutation panel showed RUNX1 mutation with a VAF of about 93%. So that would be quite high for a typical somatic gene mutation. So that should get you thinking about other explanations there. This patient was treated with standard 7+3 chemotherapy. After count recovery, she achieved a remission, and we would say that she had a CRI, because she didn't completely normalize the platelet count. But of course, as we know, this patient probably never had a normal platelet count. Cytogenetics now show normal karyotypes. This is quite a deep remission. And repeat molecular testing now shows no detectable NRAS mutation, but the RUNX1 is still detected, but now at about 50% variant allele frequency. So what's going on? I think there are many clues that this patient has an inherited myeloid malignancy. She's diagnosed with AML at a very young age. Remember, the median age at diagnosis for AML is 68. she has this strong family history. And another clue is that the RUNX1 gene mutation, which is a known germline mutation that can predispose a patient to developing hematologic malignancy like MDS or AML, doesn't clear when the NRAS, which is a somatic mutation, does clear. So those are all clues that this patient may have her leukemia because of an inherited germline situation. RUNX1 familial platelet disorder is an inherited condition that causes low platelet counts, but also can predispose a patient to a myeloid malignancy. And the estimated lifetime risk of this for such a patient to develop MDS or AML is upwards of 50%. And a very high percentage of patients that don't have a diagnosis of MDS or AML still have a CHIP mutation associated with their bone marrow, which shows the sort of predisposition for this disease evolving. Interestingly, the patients with germline RUNX1 mutations can develop somatic mutations in the other RUNX1 allele. And that's what explains our patient having a VAF of around 100%, but then it coming down to 50% at remission because the persistent clone in the germline tissue is still detected, but we've cleared the leukemia, and so you no longer detect that RUNX1 mutation. And upwards of 40% of patients with MDS or AML with an inherited germline RUNX1 mutation have this scenario. Historically, having a somatic RUNX1 mutation puts patients into the high-risk category. They don't do well with standard conventional intensive chemotherapy. Whether that applies to newer therapies like venetoclax-based therapies remains to be seen. But historically, patients with the germline RUNX1 mutations have also had worse outcomes when they develop MDS or AML. And there are retrospective and prospective studies to sort of explore this more now that the community is really looking for this, as we should be. Guidelines for inherited malignancies really consider this or start thinking of this strong family history of either hematologic malignancies or even cytopenias. A younger age at diagnosis is something that should get people thinking, but not all of the inherited gene mutations that cause these conditions present at younger age. So the DDX41, for instance, is a mutation that's inherited but causes AML or MDS to occur later in life, in the 60s or 70s. And a mutation in a gene that's known to cause an inherited myeloid malignancy should be thinking about the potential for a germline condition there. When you do germline testing, you have to find non-neoplastic tissues that don't have risk of blood contamination. So cultured skin fibroblasts from a skin biopsy have been preferred, but there are other ways to do this as well. Patients with these conditions should be referred for genetic counseling and really carefully thinking about how to get stem cells for patients who need a transplant so that you don't propagate this disease from an affected family member is an important consideration as well. So comprehensive molecular testing is really necessary at diagnosis and at relapse for patients with MDS and AML. Knowing more about the mutational landscape is important for prognosis. It's important for therapeutic decision-making. And molecular testing, just routine molecular testing, can help identify those patients with inherited myeloid malignancies, but know that there are some mutations that are not covered in the somatic panels. And so if a germline mutation is suspected based on some of those clinical signs and symptoms that we discussed, then you would want to employ the use of a genetic counselor and or a specialized panel that's designed for germline testing. Thank you so much. Thank you for your attention.
Thank you very much, Dr. Pollyea, for such a clear and thoughtful presentation on the value of comprehensive genetic sequencing for both MDS and AML. I'm really looking forward to our discussion in a moment, but before we jump into a Q&A session, I really wanted to take the opportunity to quickly let our audience know about some helpful resources to them when they're in their clinical practice and having to order these tests and perhaps confront themselves with a variant that they haven't seen before, or perhaps are curious as to whether there are any ongoing clinical trials that their patient could match up to based on their molecular profile. So here, as you can see on the slide, there are really a number of organizations that have a ton of relevant information on their websites regarding molecular aberrations in MDS and AML. These are just a few to consider, but I'm sure there are many others out there. And hopefully you can find these as a helpful resource to you. In addition, when, not if, when you diagnose a patient with a deleterious germline mutation, there are quite a few patient organizations, including nonprofit disease-specific organizations, as well as consortia that may be helpful. So, for example, at RRP, we support a consortium of expert physicians and genetic counselors who are really focused on inherited hematologic malignancies. And those individuals within that consortium could be a great resource should you confront a germline patient in your practice. So there is the name of that consortium on the top left. And on the top right, if you ever have, for example, a question about a RUNX1 patient or a RUNX1 variant, you can access this RUNX1 database, which has collected and curated RUNX1 variants from across the world and is really a helpful tool and resource to clinicians. I'm certain that this is not an exhaustive list of all the organizations and all the relevant diseases, but here, again, are just a few that we're aware of and a few that we've had a chance to work with. And they all offer various levels of research and clinical support, as well as patient services and advocacy. And then here is also a list of additional organizations that are patient-facing and have helpful resources for patients with MDS or AML. So not just, of course, the germline patient with MDS or AML. Many of you are probably aware of large organizations like LLS, but there are maybe some new organizations on this list that you haven't been exposed to. For example, No AML is the same team that established the AML Hub for clinicians. The No AML Hub is really patient-facing and has a lot of information about AML therapies, what to expect when you have AML, that kind of thing. And of course, on the previous slide where I mentioned we had a number of these disease-specific heritable heme malignancy organizations, those organizations also have patient resources, just like we do at the RUNX1 research program. So with that, I think we can move on and begin our discussion. So please, again, ask any and all of your questions by using the Q&A icon. We are ready to start the discussion, and I hope everyone's been jotting down and writing their questions within the icon there. I'm delighted to welcome Dr. Mannis and Stein to our virtual panel. Dr. Mannis is Assistant Professor of Medicine in the Division of Hematology at Stanford University, and Dr. Stein is Chief of the Leukemia Service, Director of the Program for Drug Development in Leukemia, and Associate Attending Physician of the Leukemia Service in the Department of Medicine at Memorial Sloan Kettering Cancer Center. Welcome to you both, and let's get this started. And unfortunately, we had to let Dr. Pollyea step away. So we'll have a discussion. We'll be just fine. We're in good hands. We'll have a discussion with Dr. Mannis and Dr. Stein. So please remember to add your questions to the Q&A. And I'm going to start here with the first one. The first one being, Dr. Pollyea started off with discussing the many different genes that are mutated across MDS and AML. And I know that there are a number of different NGS panels that are available, each with varying numbers of genes included. How do you both decide what panel to use and when? And maybe I'll start with you, Dr. Mannis.
Yeah, it's a great question. First, thanks for having us. This is a really important topic. I'm happy to be here with my buddy, Dr. Stein. Good to see you, Eytan. Part of the challenge, especially for the, practicing oncologist, hematologist who doesn't see loads and loads of AML patients is that this has really been a rapidly evolving landscape, and there hasn't been a standard sequencing platform, and they can range from a 5-gene panel to a 30-gene panel to a 500-gene panel, and it's hard to know which is best to order. And as part of the NCCN panel, we have had spirited debates about what to put in the guidelines. Should we put a certain minimum number of genes that should be tested for? And in the end, we left the language relatively vague. But I think my sense is that a minimum of 30 to 50 genes probably gets you the most common prognostic predictive genes, plus hopefully some of the germline mutations, which Dan highlighted. I think the more comprehensive, the better, but I understand the limitations from the community provider in terms of cost of these panels, time for turnaround, and so I think those factors will play into it.
Thank you. What about you, Dr. Stein? Anything to add from your perspective?
No, thanks also for having me. I really appreciate it. Gabe, I like that picture of the red blood cell on your wall. It's very cool. So I agree with Gabe. I think that a 30 to 50 gene panel is sufficient. It's interesting, in acute myeloid leukemia, there really are only about 30 to 50 genes that are recurrently mutated. So when you go beyond that, it's interesting academically, but whether it makes a huge difference therapeutically is questionable. When you're doing germline panels, though, those panels really are separate, and they're looking for genes that are more rare, like DDX41, et cetera. So those panels, at least at our institution, are actually done on a separate platform, separate set of testing that is done.
So interesting, you bring up germline testing, and I think one of the most frequent challenges that we hear about is the length of time to get germline testing returned, and this is especially important when you're dealing with AML and you're trying to get to a transplant. Is this getting any better, and how do you manage that challenge?
Yeah, so in our institution, it actually comes back relatively quickly, and by relatively quickly, I mean within 3 to 4 weeks, which is enough, though, to make a decision about transplant, or what kind of donors you're going to use for a transplant. The way to get this back more quickly is honestly advocacy when it comes to pushing pathology groups to work a little bit more quickly. My understanding is that with the current technology, it can be done much quicker than that. But things get batched, and I think there's a cost savings for not running these panels every day. So I think advocacy that pushes sort of pathology societies who actually control the testing being done is the way forward, and the way to get these things back in less than 3 or 4 weeks.
And I would just add, I think, turnaround time is important, but really the bigger issue in the community probably is just recognizing when germline testing should be done. And as Dan pointed out, there are really a few ways to sort of suspect it. One is a strong family history. One is, a really high variant allele frequency in a gene that is associated with germline malignancies. But then, and I just had a very similar case where a patient had an NPM1 mutated AML and a slew of other mutations. And after achieving remission, all of the mutations cleared except for this CDBP alpha mutation, which was present at a high VAF. And so, there are a couple of ways to suspect it. And I think that's, I think getting that message out there that it's, we used to say, and when I say, used to 5-10 years ago, I would say, AML is not really passed down in families. And now increasingly we know that there's probably a much higher percentage where that is the case.
Yeah, thank you. We have a question here, and I'm going to just read it off to you both. and maybe I'll direct it to you, Dr. Stein, because it's about New York. States like New York that require use of CLIA certified labs may offer germline testing for patients with heme malignancies, but their assays are not validated for fibroblast samples, whereas other labs have contracts with labs that offer cell culture and extraction, but will not send to outside labs contracted with patients' insurance. Can you comment on the use of saliva samples for these patients to offer at least some preliminary data?
It's a good question. I don't know the ins and outs of sort of the regulatory landscape of New York State, thank God. But I can comment on the answer to that question. So, the concern with saliva, of course, is that it's going to be contaminated with blood, right, which is where the tumor is located. I'll tell you what we do at Memorial Sloan Kettering for all of our germline testing. We actually use fingernails. So we give our patients, there's some poor person who has to go to Dwayne Reed and buy a bunch of nail clippers and then hand them out to the patients, and they clip their nails into a little receptacle, and that's where we get our germline data from. Of course, it doesn't require fibroblast culture. It's easy and quick, and it gives a very accurate result. So saliva, I guess if you've got no other option, you could try that, but I would try to go with another option like fingernails. Great.
Yeah, fingernails. I haven't heard too many people using that. I didn't realize that Memorial was using fingernails so regularly. Dr. Mannis, are you pretty much using skin punch biopsies?
We are, and it is challenging. Unless we went through a process of having some of our own APPs trained to do them, but previously had to send them to dermatology. So it can be logistically challenging. Fortunately, we have a workflow, but I like the fingernail idea. I know some people will do hair. In my case, that wouldn't really be feasible, but yeah, we are still doing skin biopsies.
Great. And actually, there's a follow-up question that came in regarding, is there any difference between a buccal versus just saliva for cases where there's no skin punch? Do either of you feel there's much difference?
I actually don't know the answer to that question. I don't think there would be much difference, but I don't know for sure.
Great. And then there's lots of germline questions. Maybe we have a selection bias here. Are there any recommendations on panels to use for donor testing? Or are most of the panels pretty comprehensive that you're aware of? So transplant donor, that is, I assume, is the question here.
Yeah, that's a really interesting topic because I don't know that it is universal or even common to do mutational testing routinely on donors. I suppose if there is a suspicion that a potential recipient may have something germline and they're going to use a related donor, then testing is probably done. I know there has been discussion about implementing more universal mutational testing for donors to look for things like CHIP. Many older donors may have somatic mutations that you might not want to transmit to a recipient. But I'm not familiar enough with the transplant sort of algorithm in terms of testing donors. I don't know, Eytan, if you guys have a policy.
No, I'm also not familiar with that. I think we don't routinely test donors for germline abnormalities unless we found that you would find that in the patient before you, and then you just wouldn't use that donor, the related donor.
I actually, as a follow-up question, I'm curious, when you do testing in donors and you identify CHIP, is there guidance and are there guidelines around, is it pretty much any CHIP, you don't use that donor, or?
I suspect there's not a standard answer to that question. I think increasingly we are learning that, the more mutations that are present, there are certain mutations that are higher risk in terms of CHIP progressing to MDS AML. And so my guess is that going forward, that may become part of the transplant screening process, but I think it's still sort of not ready for prime time.
Right, and my memory is that there's somewhat conflicting data on this. There's this unexpected paper published in the JCO, maybe from, I think, the Harvard group, showing the patients with donor-derived CHIP actually have a better outcome post-transplant than patients without donor-derived CHIP, which doesn't really make any sense. But I think, like as Gabe said, we don't really know what to do with this yet. I mean, the other problem is that if you think about, if your donor is an older patient, the incidence of clonal hematopoiesis goes up pretty dramatically in the general population as people age. So then are you going to start eliminating huge groups of people from donating? So I think it's a little bit of a can of worms that still needs to be worked out, like Gabe said.
Yeah, I think I remember the paper you're talking about. I think it was from Coleman Lindsley's
Yeah,
group.
from Coleman. Yeah, exactly.
DNMT3A, I think somehow there were better outcomes, which was,
it was totally
counterintuitive.
Bizarre, right?
Yeah. Wow, so lots of interest around this whole transplant question. So I'm going to read another question here. We are having a difficult time getting our bone marrow transplant team to refer patients that we flag as needing genetic counseling or testing. We've provided education to explain the benefit that genetic testing can have, and we sit on their case conferences and speak up, asking that certain patients be referred, but we're not receiving referrals. Do you have any suggestions to drive home the importance of germline genetic testing to increase physician buy-in? Ooh, I'm putting you guys into the hot seat here.
Yeah, I mean, I think, we've talked a lot about donor selection for transplant, but, the implications for germline testing much more commonly are on the patient's family members, on their children. And so, in particular with DDX41, which tends to present around the same age as most sort of de novo AML, that may have implications for the children who don't have thrombocytopenia, who are fine. And so, if it's sort of advocating for why do it, it's not just the transplant issue, it's the, helping family members understand what the implications might be, screening potentially starting at a certain age for, various pre-malignant conditions. So, I think the referral is important. I'm not sure why a transplant team would push back on it.
Yeah, I mean, I guess there's the sort of academic way to go about it, and then there's the managerial way to go about it. So the academic way to go about it is to, point to NCCN guidelines and ELN guidelines, showing that it's really important these patients get referred. I mean, I think that most societies and guideline committees believe that now. The other way to do it, if you're still not getting it, is basically take it out of the hands of the people making the referrals, right? And you say that if someone has a certain history, meets certain criteria, that you're going to send an email to the doctor saying this patient meets these criteria, and we're going to call them up, let us know if you have any objection, right? So they have to refuse it instead of say yes, and that seems to work.
I like that idea. So just change the process, the workflow.
Yeah,
that's a great idea. So another question, I'm going to shift gears a little bit, and that's now back to sort of the somatic mutation testing and the value of the importance that the value can have on treatment decision making. And one question is, now that there are several IDH1 inhibitors available, and you identify a patient who has an IDH1 mutation, how do you actually, are there distinctions between the two drugs available that you say, okay, maybe there's different variants that are more responsive to one over the other, or what is the latest, and how do you make a decision on which drug?
Yeah, so it's a very good and hard question. I mean, so it's very difficult to know because the drugs have never been compared head to head, nor will they ever be compared head to head. The side effect profile of the two IDH1 inhibitors is different. the newest IDH1 inhibitor, olutasidenib, can cause liver function test abnormalities, while ivosidenib can cause issues with prolongation of the QT interval. There's this strange result, which no one really knows if it's real or not, or if it's some statistical blip, that in the ivosidenib trial for relapsed and refractory AML, the duration of response in patients who achieve a complete remission is around, I think, 8 months or something like that. But the duration of response in patients who achieve a complete remission with the newer drug is reported as 25.9 months. So
Wow.
it's hard to understand how that could be, because the drugs seem to be biochemically almost equivalent, very, very similar. So I can't say that there's a benefit to one over the other. I personally use a lot of ivosidenib because I'm comfortable using it and I know what the side effects are, but that's my own personal bias and not based on any data.
Makes sense. What about you, Dr. Mannis?
Yeah, same. I've used Ivo for a long time because it's been around longer. I think my sense is, there are slight differences in side effect profile, which might make you choose one over the other for a particular patient. I do think it's hard to interpret the duration of response difference in these two trials. Yeah.
What about, and I don't know how frequently this may happen in practice, but what about managing, having a patient that has 2 clinically actionable mutations? How do you decide, which drug to start with? So FLT3 and an IDH1 mutation, for example.
Yeah, that's a tough question, and I'm not sure anybody knows the right answer yet. One of the other advantages of NGS testing that I think really wasn't mentioned is that you can use the variant allele frequency to sort of get a sort of sense of the clonal architecture. We think, AML is a clonally diverse heterogeneous disease, and the NGS is bulk sequencing. So it's not telling you at the cellular level where the mutations are. But say, for example, if you had a patient with a really high IDH1 VAF, and there was really just a small FLT3 clone, for example, I might start with IDH targeting. I don't know if that's the right answer. And it would depend, I think, are we doing intensive, is this a newly diagnosed patient? Is it a fit patient? There are a lot of things that go into it. And of course, people are now studying combinations of drugs. So, the way we develop drugs, typically we, start them as a single agent, then put them into combination. And so you're now seeing doublets, triplets. And so, maybe combination is the way to go, maybe sequencing, but I think we're still figuring those things out.
I'm just going to jump in and put a plug in for a trial we opened last week, which is the combination of IDH inhibitors with FLT3 inhibitors in patients with co-occurring mutations. There are people who have done this off-label, and they actually had an abstract that they submitted to ASH a couple of years ago. It didn't get accepted at all, but it was in like that book that you get afterwards. And it showed some responses. So we're hoping that this trial shows benefit for patients.
Oh, that's exciting. So what is how frequently does that happen?
That they're co-mutated?
Yeah.
Yeah, so of patients who have FLT3 mutations, about 30% of them will also have IDH mutations, but what's interesting also is that when you have an IDH mutation and you're on a single agent IDH inhibitor, one of the mechanisms of resistance is that a FLT3 mutation will pop up. So the trial allows that if you're on ivosidenib or whatever, you can then add on the gilteritinib to the or that's the drug we're using in this trial to the ivosidenib.
Great. Well, yeah, happy that you put out that plug. There's another comment actually in the Q&A here, so it's not a question, but that someone was mentioning that the problem of germline versus somatic panels can be, you can get around it by making sure you include as many germline genes as possible in your somatic panel, and at least you get that first blush based on VAF of whether there's deeper sequencing you need to do. So I think that's a helpful comment. I have no more Q&A questions in our list here, and so I want to give people maybe a few more minutes to add anything else, any other burning question. And in the meantime, maybe there's any closing thoughts from why don't I turn it to you, Dr. Stein? Any closing thoughts about the importance of molecular profiling today in MDS and AML?
Yeah, so I mean, I think I'll just state the obvious, which is that molecular profiling in MDS and AML is really crucial, not only to understand the prognosis of the disease and to make transplant decisions once a patient is in remission, but it's also predictive of response to various targeted therapies. And the number of targeted therapies that are going to be used in the frontline setting in combination with chemotherapy is just going to increase. We're now going to have various other inhibitors that are coming down the pike, and I don't really think I don't think you're practicing great medicine in 2023 if you're not doing some sort of mutational testing, whatever that panel might be.
Great, thank you. How about you, Dr. Mannis? Anything you'd like to add?
I would just add that a lot of the referrals that I see, the referring provider will have sent a panel of actionable mutations. And, historically that's included FLT3, IDH, maybe NPM1, CPP alpha. But, as we've heard today, there are a lot of other genes that have implications for what action to take in terms of referring for transplant, in terms of germline testing, in terms of the initial therapy. And so I think this term actionable mutation really has, expanded to a whole slew of genes. And so it really is, I think, crucial. And I think, for those who, might be confused by the menu of NGS panels that are now orderable, certainly always, reach out to your local AML MDS person and just get I'm always happy to recommend a panel or do the testing here. So
thank you for that. Yeah, I think part of these webinars is also just to introduce especially the community physicians to new experts maybe in their local region, and so thanks for offering to step in and help. So thank you both. I really appreciate your insights and the answers to all these questions. And if Dan was here, I would say thank you to him as well. Hopefully he was able to take care of what he needed to take care of. And with that, enjoy the rest of your Wednesday.